This lecture will be going over Chapter 4, Care of Preoperative and Intraoperative Surgical Patients in the MedSurg textbook. Surgery is performed for a variety of reasons. It can be elective, urgent, or performed as an emergency. In a hospital, surgery might be performed as the same day or an outpatient procedure, or it could be an inpatient procedure. Minor surgery is often performed in a healthcare provider's office. Licensed LPNs can assist more often with surgery in this type of setting. For any type of surgery, preparation will always begin before admission. The ability to deliver and reinforce teaching for our postoperative and home care patients is crucial to their well-being as well as their quick recovery. We have different reasons for surgery. Diagnostic surgery will be performed to determine the origin and cause of a disorder, or the cell type for cancer. A curative surgery is performed to resolve a health problem by repairing or removing the cause. Restorative surgery is performed to improve a patient's functional ability. Palliative surgery is performed to relieve symptoms of a disease process, but it will not cure. Cosmetic surgery is performed primarily to alter or enhance personal appearance. We have different urgencies of surgery. Surgery can be elective. This means that it's planned for a correction of a non-acute problem. It can be urgent. That means it requires prompt intervention and could be life-threatening if treatment is delayed more than 24 to 48 hours. Or it could be emergent. This requires immediate intervention to prevent any life-threatening consequences. We have a degree of risk of surgery. Surgery can be considered minor. This would be a procedure without significant risk, typically done with local anesthesia. Or it can be major. This would be a procedure of great risk, typically longer and more extensive than a minor procedure. And we have different extents of surgery. It could be considered a simple surgery. This will typically be only the most overtly affected areas involved in the surgery. It could be a radical type of surgery. This is an extensive surgery beyond the area that is obviously involved. It is typically directed at finding a root cause. Or it could be a minimally invasive surgery. This is a surgery performed in a body cavity or body area through one or more endoscopes. It's typically done to correct a problem, remove an organ, or take a tissue for biopsy, reroute blood vessels, or drain systems. This is a fast-growing and ever-changing type of surgery. All of this information can be reviewed in Table 4.1 on page 64. Laparoscopic and endoscopic procedures have replaced many open surgeries. That would be a surgery in which a large incision is necessary. This has resulted in less trauma to tissue, less inflammatory response, and less pain, as well as a faster recovery. Endoscopic surgery, in which fiber optic technologies are used to visualize interior structures of the body, operating microscopes and lasers are now commonplace in a surgical suite. Medical robotics will provide a key to a less invasive and less traumatic surgery. A medical robot can be operated from a nearby computer, while the surgeon views magnified three-dimensional images of the surgical field on the computer screen. The robot's tiny camera has multiple lenses that allow magnification up to 12 times that of normal vision. The primary surgeon at the computer will use the robot to perform the surgery. And this type of technology provides precision that is beyond human dexterity. With robotic surgical techniques, the patient will experience less scarring, and the surgical wounds will heal faster. Surgeries can be transmitted via video conferencing to locations all around the world to enhance the skill levels of surgeons everywhere. Since the mid-1980s, patients have been undergoing elective surgeries and have had the option of banking their own blood before surgery in case they need a transfusion. This is considered an autologous transfusion, where blood is prepared for your own transfusion in the future. Access to autologous procedures has greatly decreased the anxiety of patients who fear infection with a blood-borne virus, such as HIV or hepatitis B or C. Bloodless surgery can use a combination of techniques to minimize blood loss and maximize blood volume and function. Epoetin alpha, or Epigen or Procrit, can be given before surgery to stimulate red blood cell production, and hemostatic agents can be given before or during surgery to promote clotting. During surgery, the surgeon might request induced hypotension or hypothermia to decrease the oxygen demand on the body. Another bloodless surgical technique is hemodilution. This is where several units of the patient's blood are removed, then replaced with crystalloids or colloids. This is to expand their vascular volume. Perioperative nursing refers to the care of the patient before, during, and after surgery. Before surgery, the patient should be in the best possible physical condition. To determine your patient's readiness for surgery, a thorough health assessment is conducted and risk factors need to be considered. Take a look at the older adult care points on page 66 in the red box. Patients older than 75 years of age have a surgical complication rate 3 times higher than that of younger adults. An older adult patient is less able to adjust and compensate for the stress of surgery due to their physiologic reserves declining with age. Older adult patients are more likely to have impaired renal, hepatic, respiratory, and cardiac functions that will alter their metabolism and their excretion of drugs and anesthesia. The presence of chronic diseases will cause vulnerability to fluid and electrolyte imbalances during and after surgery. When assessing your pre-surgical patient, any significant deviations from normal range need to be brought to the attention of the surgeon. Knowing your patient's usual blood pressure reading is necessary for comparison after surgery to determine your patient's stability. Height and weight are measured and charted before surgery, so the anesthesiologist can accurately calculate their anesthetic dosage. Assessment for particular risk factors for surgical site infection would include pre-existing infection or medical condition, a nasal bacterial colonization, malnutrition, advancing age, diabetes, nicotine use, immunosuppression, and obesity. It is particularly important to know if a patient is taking a corticosteroid. This can delay wound healing. It can also alter fluid and electrolyte balance, as well as several different metabolic functions in the body. This is a factor that increases a patient's surgical risk. Patients need to be questioned about medicines and eye drops that could contain a corticosteroid. Corticosteroids should be tapered slowly before surgery, but never stopped abruptly. This information is extremely important to share with the healthcare team. Vitamin E, aspirin, and other NSAIDs, as well as anticoagulants, will have a continuing effect on blood clotting for several days. Therefore, they should typically be discontinued about 7 to 14 days before surgery. Nutritional status and body weight are also significant factors in healing and repair of the surgical site. Obesity can cause prolonged uptake of anesthetic drugs. The news that surgery is needed will typically come as an emotional shock to patients and their families. Surgery can cause changes in the routines of their lives that can result in personal and financial burdens. In any event, there will be fears and misgivings about the prospect of undergoing anesthesia and surgery. Take a look at the cultural considerations on page 67. Cultural beliefs and values regarding surgery need to be taken into consideration. If a female patient's culture has strict rules for female attire, she will need assurance of sufficient privacy and protection of her modesty to allay any fears she might have. Issues and interventions need to be conveyed to the surgical team. If there are any cultural taboos regarding an aspect of the surgery, the surgical team needs to know about this and plan a way to achieve a good outcome without violating any cultural taboos. It's also extremely important to know whether or not a patient will accept a blood transfusion. Determine if your patient will have adequate help at home after their discharge from the hospital. Some patients will benefit from a short stay at an acute rehab facility to regain their strength and independence before they go back home. Some patients will have a strong spiritual belief that will help them cope independently with their sickness, suffering, and possibly death. Others will need help in finding the spiritual support that they need. Allow time with the clergy or a spiritual advisor before the surgical procedure, according to your patient's desire. Laboratory and diagnostic test data. A chest radiograph should be obtained and an EKG ordered for many patients over 40 years old. If the patient has any history of lung disease, pulmonary function tests could be ordered. If the laboratory reports indicate any abnormal values, surgery could be postponed. Elevated liver function tests could put the patient at risk of excessive bleeding and surgery. If you take a look at page 68, box 4.2 will show you some commonly ordered preoperative tests. Notice the metabolic panel includes liver function tests such as AST, ALT, and bilirubin. Elevated levels of these tests could put the patient at an excessive risk of bleeding and surgery. Surgery will put a strain on the cardiovascular, renal, and respiratory systems. Liver function is important because the liver is involved in synthesizing many clotting factors, producing albumin, and metabolizing and detoxifying drugs. Although requesting preoperative diagnostic tests is typically the responsibility of the healthcare provider, you will be responsible for explaining to the patient why these tests are ordered, as well as reporting to the provider any significant abnormalities. Infants and older adults are at a higher risk of complications of surgery due to their immature body system or a decline in function of various body systems. Although smoking or vaping is a risk factor, research has shown that quitting smoking and alcohol intake 3 to 8 weeks before surgery can reduce the incidence of serious postoperative complications. General information should be provided to the surgical patient about what will happen immediately before, during, and after surgery, as well as any specific preventative measures. If members of the family or supportive friends are expected to assist the patient during their postoperative period, they also need to be included in any teaching sessions. When planning, some general goals for all preoperative patients is the expectation that the patient should be prepared for surgery physically and emotionally. They need to be able to demonstrate deep breathing, coughing, and leg exercises. They need to be able to verbalize understanding of their procedure as well as expectations for their postoperative period. And they need to be able to maintain fluid and electrolyte balance throughout their perioperative period. When preoperative patients are assigned, you need to plan your work for the shift carefully to make sure your patient is ready for surgery without neglecting the needs of your other assigned patients. On page 69, we can see some surgical risk factors in table 4.2. Notice that excessive fear is a surgical risk factor. This can cause release of hormones, causing swings in the body's chemistry and vital signs. The patient will require further instruction in order to be emotionally prepared for their surgery. Preoperatively, you need to divide your time between preparing your patient for surgery and teaching them about what will happen and how to hasten their recovery. Teaching sessions need to be scheduled when the patient comes in for diagnostic testing. Sending written instructions home with the patient can also reinforce the information that has been taught. Protocols can differ from one facility to another. Before the surgeon can perform an operation, written permission signed by the patient, guardian, or whoever holds power of attorney needs to be obtained. This is considered your informed consent. In most hospitals, the consent is a printed form that the patient signs before surgery. The correct surgical procedure is identified on the consent form. The surgeon explains the procedure, risks, and benefits. The patient must be mentally competent and give consent freely and without coercion. Your signature on the form will confirm that the patient understands the procedure that they are consenting to and have had all questions answered. You must always check that a consent form has been signed before giving any preoperative medications. In an emergency situation, if a patient was not capable of giving consent due to their condition, a relative cannot be reached, and delaying surgical intervention would put the patient in jeopardy, then surgery can proceed without a signed consent. Food and fluids will often be restricted for 8 hours before surgery, and the patient is placed on NPO status. Often the surgeon or anesthesiologist will allow an oral blood pressure medication or heart medication or anticonvulsant to be taken, typically just with a sip of water in the morning of their surgery. Always check your healthcare provider's orders before giving anything by mouth, including medication, in the immediate preoperative period. Always confirm with your patient that they have actually heeded their NPO order. If the patient is having abdominal or colon surgery, a colon lavage solution or enemas may be ordered to clear the intestines of fecal matter. When completing the preoperative checklist, ask your patient to empty their bladder, unless a catheter is already in place. If the bladder is not emptied, relaxation induced by medications or anesthesia can cause the urge to urinate. The bladder needs to be emptied before any sedating medication is given. If an NG tube will be inserted during surgery for postoperative use, you must explain its purpose, how to care for it, and what it will feel like to your patient. The tube will usually be removed when bowel sounds have returned and nausea has passed. Explain the function of any other tubes and drains, such as an IV line, any oxygen delivery and monitoring devices, a chest tube, a urinary catheter, as well as their care and probable duration of use. It is desirable for the patient to be as well rested as possible before surgery, so the body is not compromised in meeting the stresses of anesthesia and the surgical procedure. Many surgeons will order a patient-controlled analgesia pump, or PCA pump, for their patients postoperatively. If a PCA pump is ordered, patients should receive instructions before surgery about the pump and how to operate it. Explain that asking for the pain medication before the pain becomes severe will make it much easier to control their pain level. It is your responsibility to gather data regarding your patient's pain throughout your shift and to offer interventions for their relief. The night or morning before surgery, the patient may be asked to shower with a special antibacterial cleanser or just soap and water to remove as many microorganisms from the skin as possible. Be sure to use hair clippers only for hair removal before surgery. Nail polish should be removed so that the pulse oximeter can function correctly when attached to the finger. Teaching the patient correct breathing, coughing, turning, and leg exercises is high priority during the preoperative period. It is helpful to have a relative or close friend present for these teaching sessions so that that person can later coach and give encouragement to the patient. Venous return is often hampered during the surgical procedure due to the position assumed on the operating table and pooling of blood in the lower extremities. Stasis of blood will put the patient at risk for thrombophlebitis. Specific leg exercises will prevent this complication. One way to remind patients to do their exercises is to have them exercise whenever a commercial comes on the television. The exercise should be done after surgery at least 5 times every hour while awake until the patient is up and moving around normally. Use of pneumatic anti-embolism stockings, leg exercises, and low-dose heparin therapy should be used for DVT prophylaxis in any bed-bound patients or those with limited mobility. For deep breathing and coughing, it is preferable for the patient to sit up with the back away from the mattress or chair. The surgical chest or abdominal incision needs to be splinted with a pillow. The surgeon might order the use of an incentive spirometer. You will need to instruct the patient in its use and supervise them until they have mastered the technique. Show the patient how to turn in bed by flexing the legs to relax the abdominal muscles. Place a pillow between the legs and grab onto the side of the bed, slowly turning onto their side. This maneuver should also be used for getting out of bed. Advise the family to come to the hospital 1 to 1.5 hours before surgery. The family needs to be told about the usual routines, where to wait, the approximate time before the patient is expected to return, and what to anticipate in the way of tubes, equipment, and patient appearance after surgery. A warning about occasional delays in starting surgery can help keep the family from becoming excessively anxious if the patient is not back at their expected time. The patient is usually dressed in a clean hospital gown without underwear for the OR. Hair is covered with a surgical paper cap. Long hair should be fixed to minimize any tangling, and all hairpins and barrettes need to be removed. Explain why all jewelry must be removed for safety due to the electrocautery used during surgery and the danger of an electrical burn from conduction of electricity through metal. Jewelry, along with money and credit cards, needs to be given to a family member or relative to keep secured, or can be placed in a valuables envelope and given to security according to your facility policy. If a wedding band is to be worn to surgery, you must tape the ring to the finger without restricting the circulation. Then tape a cotton ball over the stone to prevent any loss when the tape is removed. Dentures are removed, should be placed in a labeled cup and kept in a designated place according to your hospital policy. If a hearing aid is left in place, a very visible note needs to be placed on the front of the chart, and placement of the hearing aid should be noted on the preoperative checklist sheet. Verify that the ID bracelet matches the chart to avoid any error or mix-up of patients in the OR. Verify the procedure site indicated on the surgical consent form is the same as what your patient states. Make sure that all diagnostic tests have been completed and results are available, reporting any significant abnormalities. Most preoperative medications are given by the anesthesiologist immediately before surgery. You might need to send an IV piggyback, antibiotic, or other medication order to the OR with the patient. Preoperative medications may be given to reduce anxiety and promote a restful state, to decrease secretion of mucus and other body fluids, to counteract nausea and reduce emesis, to enhance the effects of an anesthetic. Take a look at the safety alert in the red box on page 76. Preventing falls. If the patient has received a sedative preoperatively, remember to put the side rails of the bed up per your bed facility policy, and then lower the bed. Place your call light button within reach and remind the patient not to get up without assistance. These are very important safety measures after administering a sedative. Take a look at the cultural considerations on page 76. The ability of the body to process chemicals is influenced by age, sex, and your race and ethnicity. The FDA tracks research regarding pharmacogenetic associations that affect drug metabolism. Information is available to help guide drug usage and dosing based on race or ethnicity. The presence or absence of specific genes can dictate how medications are used by the body. While patients are in surgery, prepare the room for their return. Make the bed with fresh linens, including a drawing sheet between the shoulder and knee areas that can be used as a lift sheet to reposition your patient, or place a lifting device sheet or pads as needed for your individual patient. Raise the bed up to the height of the stretcher that will return your patient, and arrange any furniture so that the stretcher can easily be pulled up along the side of the bed. Having the bed ready will be helpful to the transport process. Place the IV pole or pump at the head of the bed. Gather an emesis basin or bag, tissues, a frequent vital sign sheet or postoperative record, an intake and output sheet, and a small towel and washcloth. Place these items at the bedside table or console. A thermometer, sphygmomanometer, pulse oximeter, and stethoscope should be close at hand on the patient's return to the unit. Communication with the PACU nurses is helpful in identifying the devices that have been implemented in the OR or PACU and those that need to be available on the receiving unit. If your patient is properly prepared for surgery, kept NPO, and is reasonably calm and knowledgeable about their procedure as well as what is expected, then all general goals have been met. The surgical team consists of the surgeon, assistant to the surgeon, anesthesia care provider, circulating nurse, and scrub person or scrub technician. The first surgical assistant is another physician, a physician's assistant, a surgical resident, or a specially trained and authorized RN or surgical technician. The surgeon, physician assistants, and scrub nurse or scrub technician are sterile members who work within the sterile field, maintaining asepsis with surgical attire of sterile gowns and gloves. The circulating nurse and anesthesiologist or anesthetist do not work within the sterile field, and they do not wear sterile gowns and gloves. ORs are removed from other areas of the hospital, and access is restricted to the OR personnel and surgical patients. Clean scrub clothes and caps are required. The temperature in the OR is kept at 66 degrees to 70 degrees Fahrenheit. This is to discourage any microbial growth and keep the surgical team comfortable under the bright lights and in their layers of surgical clothing. The restricted area is scrubbed down with disinfectant after each procedure. The entire room is kept scrupulously clean. The patient is transported to the holding area in the surgical suite. The holding area nurse, often the circulating nurse, will greet the patient and verify their identification. The correct surgical site markings are checked. You should offer emotional support and answer any questions. The anesthesiologist may greet the patient, start an IV line if that has not been established, and administer any preoperative medications, as well as prepare the patient for anesthesia. A surgical technician or specially trained nurse may be the scrub person. Sterile technique must be maintained at all times. Any break in sterile technique needs to be pointed out immediately by the circulating nurse or any member of the OR team and then remedied. The circulating nurse is responsible, along with the anesthesia care provider, for maintaining the safety and dignity of the patient and bringing any needed items to the operating team, as well as many other duties. The circulating nurse is the communication link between the OR and those outside the surgical suite. The patient will be positioned with padding to prevent any injury to nerves, as well as minimize pressure over bony prominences. Safety straps are secured to safeguard the patient. There is a risk anytime a patient is anesthetized. The goal of anesthesia administration are to prevent pain, to achieve adequate muscle relaxation, to calm fears and ease anxiety, and to induce forgetfulness of an unpleasant experience. Patients are classified according to their age, physical condition, and risk status, and then are assigned a risk potential. The choice of anesthesia will depend on the type of surgery to be performed, as well as the patient's risk potential. General anesthesia is induced by the administration of an inhalant gas or by a medication introduced intravenously. During general anesthesia, the patient is in a deep sleep state with muscle relaxation and is not aware of their surroundings. There are 3 stages of general anesthesia. First is induction. Unconsciousness is induced. Second is maintenance. This is the period during which the surgical procedure is performed. Then emergence. This is when surgery is complete, the patient is prepared to return to consciousness, and the neuromuscular blocking agents are reversed. Take a look at the older care adult points on page 79 in the red box. The physiologic changes that occur with aging will affect the way the drugs are taken up, used, and excreted. Obtaining an accurate height and weight of older adult patients is very important for calculation of anesthetic agents and medication dosages. Adverse drug responses are increased in the older adult population. In general, smaller dosages of drugs are required, and fat-soluble drugs in particular will have a longer duration of action and a slower elimination period. Regional anesthesia is accomplished by administering a nerve block. Regional anesthesia may be accomplished by injecting the spinal, epidural, caudal, or peripheral nerve area. A local anesthetic agent or regional anesthesia to numb the area plus IV sedation will be used to provide systemic analgesia and sedation during a surgical procedure. The combination can be used for any procedure that could be done with local or regional anesthesia and is becoming increasingly common. Notice on page 79 in table 4.3 the types of anesthesia. Local anesthesia is used for minor surgical procedures. Procedural conscious sedation, also called procedural sedation and analgesia, or PSA. This can be used in combination with local, spinal, or nerve blocks to enhance patient comfort. It can be IV and local. Carbon dioxide levels do need to be monitored by capnography during this procedure, or for any procedure requiring a higher level of sedation. Capnography will provide a graphic representation of exhaled carbon dioxide. Carbon dioxide monitoring can be done without intubation with a nasal cannula-like device. Local anesthesia is used for minor procedures such as superficial tissue biopsies, surface cyst excision, insertion of a pacemaker, and insertion of a vascular access device. Potential intraoperative complications of surgery include hemorrhage, infection, fluid volume excess or deficit, hypothermia, malignant hyperthermia, and injury related to positioning. No surgical personnel with an active infection should be in the OR. Counts of sponges, needles, and instruments are performed to verify that no equipment has been left in a wound where it could cause a postoperative infection or complication. Core measures and national patient safety goals include proper hair removal, timely antibiotic administration, blood glucose control, prevention of thromboembolic events, and prevention of adverse cardiac events. The cool atmosphere, cool IV fluids, inhalation of a cool anesthetic gas, and exposure of body surfaces will lower a patient's normal body temperature. Body temperature is monitored during surgery to ensure that it doesn't become dangerously low. However, if the patient's temperature does drop too low, warmed IV fluids can be administered or a body warming device can be used. Hypothermia can adversely affect cardiac function and can also make the body more susceptible to infection, as well as increase bleeding and delay any wound healing. Prophylactic antibiotics will work best when given within 1 hour of the surgical incision. Malignant hyperthermia is an inherited disorder. In patients with malignant hyperthermia, muscle metabolism and heat production increase rapidly and uncontrollably in the response to the stress of surgery as well as some anesthetic agents. Fever, tachycardia, cyanosis, tachypnea, muscle rigidity, diaphoresis, hypotension, and irregular heart rate will develop. If this is not treated quickly, cardiac arrest will occur. The circulating nurse must monitor the patient's temperature along with the anesthesia care provider. If the temperature begins to rise rapidly, anesthesia needs to be discontinued and the surgical team must take measures to correct the physiologic issue. During a surgical procedure, the patient is placed in one position for an extended period of time. This positioning will place them at risk of injury, such as problems of immobility as well as pressure damage to the skin and underlying tissues. Joint problems and pressure ulcers can develop days after surgery from damage that occurred during the surgical procedure.